Hello friends, so what we are going to discuss today is one of the most important cases or topics in any orthopedic exam, orthopedic practical exam around the globe, and additionally a topic that is a nightmare for any orthopedic surgeon if it happens post-op. And today what we are going to discuss is we are going to discuss the concept and idea of foot drop. So without further ado, what our plan for today is we are going to discuss about the course of sciatic nerve with branches and site of injury. We are going to discuss about the etiopathogenesis. And the last four topics are the most important topics. If you ask me to put my money on, I'll put on these four topics. We are going to discuss conceptually about the motor and sensory deficit. We are going to understand the site of injury based on the deficit that we see in the patient. And the most important, at the end, we are going to discuss about a key so that bang on, you can find the site of injury from the symptoms and the examination findings. And at the end, we are going to practice few cases, real-time cases, through which we can understand the etiopathogenesis and the site of injury. So without further ado, let us begin. Let us begin with the concept. First, the course of sciatic nerve along with the sites, possible, probable sites of injury. Okay, so sciatic nerve, the root value is L4, L5, S1, S2, S3. Few of the basic things. It starts at the lumbosacral plexus. It originates from the lumbosacral plexus. It goes into the gluteal region. All of them which I discuss are the possible sites of injury we are going to discuss in detail. So as I said, it begins from the lumbosacral plexus, goes into the gluteal region, reaches the back of thigh, and after that at the superior angle of the popliteal fossa, it divides into common peroneal nerve and tibial nerve. Lumbosacral plexus, gluteal region, back of thigh, reaches the superior angle of popliteal fossa where it divides into common peroneal and tibial nerve. The common peroneal nerve descends inferolaterally and reaches and winds around the neck of fibula where it divides into superficial peroneal nerve and deep peroneal nerve. Okay, so the main branch is sciatic nerve, then common peroneal and tibial nerve. Common peroneal divides into superficial and deep peroneal nerve. This was just the basic. Now, now we are going to discuss about the etiopathogenesis, possible sites of injury which leads to the foot drop. So if it happens in the spine, if it happens at the level of spine, when does it generally happen? When there is L5 nerve root compression. L5 nerve root compression usually causes foot drop. So most common pathology causing this is L4, L5 prolapse intervertebral disc. What do you look for in the patient? You look for step or tenderness at the spine. You go for a spinal examination. Not going into details of that. Okay. Then at the level, the possible site of injury could be at the level of the gluteal region. What are the possible etiologies? Most common posterior hip dislocation. Then fractures around the pelvis, fractures around the hip, that is pelvis fracture or acetabulum fracture. It might be pre-op or post-op. After fixing of the fracture, there might be a sciatic nerve injury. Post THR, post hip arthroplasty. Injection palsy, usually a neurotmesis. So what do you look for? What do you look for when you are suspecting a pathology at the gluteal region? You look for a bony mass at the posterior aspect of the hip. Additionally, you look for gluteal wasting and you look for scars around the hip, operative or injury trauma scars. Okay. Now, if the level of injury might be at the level of knee. So what are the possible causes? Possible causes are fractures around the knee with valgus or varus force. Usually causes foot drop when the injury is at the level of the knee. Other possible causes are tight compression or slab or bandages around the knee. Could be iatrogenic cause, could be mechanical irritation, could be traction, and could be osteotomies around the knee. And so what do you look for? What do you look for when you are suspecting an injury around the knee? You look for a bony deformity at the knee. Additionally, you look for any scars or calf wasting. Okay, so these are the possible, most commonly these are the possible etiologies around the knee. Now there might be a mechanical cause. There might also be a mechanical cause of foot drop when there is a damage at the foot or ankle. So there might be a traumatic damage to all tendons in the anterior compartment of foot. Other cause could be subcutaneous tendon rupture of tibialis anterior, and other less common causes are compartment syndrome, anteriorly, and Volkmann systemic contracture at the posterior compartment. So these are the most common etiopathogenesis of a foot drop we see in common day-to-day practice. There are a few systemic cause as well. There are a few systemic cause as well of foot drop, which are commonly seen in India. Diabetes mellitus. What do you look for? You look for trophic ulcers. Now, one of the characteristic cause is Hansen's disease. So whenever there is a Hansen's disease causing foot drop, you find certain characteristic features in the history, characteristic features in the examination. So first is, there is a history of patient taking medications for a skin condition that directly hints to a dermatological condition, Hansen's. Right? There might be hypopigmented patches on the skin. On further examination, there might be nerve abscess, that is, there might be some signs of neuritis and nerve thickening and tenderness around the nerve. Only affected nerves are ulnar and greater auricular nerve. Okay? And the sensation, the pattern of loss of sensations is glove and stocking pattern. So these are some of the characteristics findings which you see, characteristic hints which give a diagnosis of Hansen's disease causing foot drop. Other common systemic causes are post-polio residual paralysis, mononeuritis multiplex, motor neuron disease, stroke with equinovarus deformity, demyelination, Charcot-Marie tooth, and rapid weight loss causing neuropathy, or vitamin B12 deficiency also causing foot drop. So if there is a central cause, if you are suspecting a central cause of foot drop, what do you look for? You look for spasticity. Additionally, the characteristic feature is ankle jerk might be diminished or absent. Okay. Now, what are the three possible types of injuries? The three possible types of injuries are neuropraxia, axonotmesis, and neurotmesis. So, neuropraxia usually occur in hip dislocation, in compression and splints at the knee, tight compression and splints at the knee, and in traction, while applying traction. Axonotmesis usually occur in closed fracture around the knee, hip, post TKR, THR, and in hip dislocations. And neurotmesis usually occurs in open fractures around the knee, high energy injury, and injection palsy causing chemical neurotmesis. Okay. Some of the characteristic classic findings in foot drop, in observation of foot drop, is high steppage gait, slapping foot gait, flail ankle. What is flail ankle? That is both dorsiflexion and both plantar flexion. Both are lost. That is what we call as a flail ankle. And instability on weight bearing. Okay, so these were the basic concepts, these were the basic theoretical concepts of foot drop which you must be knowing before deciding, before seeing a case of foot drop and deciding the site of injury. Now comes the most important part for which we have gathered here today. Okay, so we are going to discuss about the motor deficit. We are going to understand the motor deficits, which will be a clue in deciding the site of injury. So whenever there is a L5 nerve root lesion, like we discussed L4, L5, PIVD. So apart from the sciatic nerve damage, that is foot drop, flail ankle, you see a characteristic classic sign, that is weakness or loss of hip abduction. So whenever a case of foot drop comes, if you don't examine spine, if you don't examine hip abduction, that is a crime. So this is the usual question asked: how do you differentiate foot drop from peripheral causes from spine causes? The characteristic answer, the standard answer is, I will check for weakness in hip abduction. Finish answer. Okay. Now if we go distally, the sciatic nerve, as we know, originates from lumbosacral plexus. It goes in the gluteal region. Now, at the back of thigh, before it divides at the superior angle of popliteal fossa, it supplies the hamstrings. Hamstrings are responsible for the knee flexion. So, if the site of injury is proximal to this aspect, then there is loss of knee flexion, there is loss of the action of hamstring. But if the site of injury is distal to the supply to hamstrings, that is just before the division at the superior angle of popliteal fossa, then hamstring and knee flexion is preserved. So this is a characteristic sign you see whether knee flexion is present. If knee flexion is present, the site of injury is more distal. The site of injury is more distal. If knee flexion is lost, the site of injury is more proximal at the thigh. So these are the characteristic signs which we discussed: loss of hip abduction, loss of knee flexion. Now it divides the superior angle of popliteal fossa into common peroneal nerve and tibial nerve. Okay, so now we need to understand the functions, the muscles supplied by the specific nerves to understand, to get the hint of the site of injury. So now deep peroneal nerve, common peroneal nerve divides at the fibular neck, winds around the fibular neck and divides into deep peroneal and superficial peroneal nerve. Okay, so what happens is deep peroneal nerve supplies the anterior compartment. Deep peroneal nerve supplies the anterior compartment, and the muscle which it supplies is tibialis anterior, which causes dorsiflexion at the ankle and inversion at the subtalar joint. Okay, so it causes dorsiflexion and inversion. It also supplies EHL and EDL, which causes great toe and lesser toe extension, and it supplies the peroneus tertius, which causes dorsiflexion and eversion. Okay, so deep peroneal nerve causes dorsiflexion at ankle and toe extension. Additionally, it also causes inversion and eversion both. Okay, keep this in mind. We are going to get these clues. Okay, now superficial peroneal nerve, it supplies the lateral compartment of leg. Okay, so it supplies peroneus longus and brevis. So it supplies peroneus longus and brevis, which the function of which is plantar flexion at the ankle and eversion at the ankle. Right. So remember this thing: deep peroneal supply causes dorsiflexion, in toe extension, inversion and eversion. Superficial peroneal nerve causes plantar flexion and eversion. Finish. Now tibial nerve supplies the posterior compartment. It supplies the posterior compartment, and the muscle it supplies is gastrocsoleus, FHL and FDL, which causes the plantar flexion at ankle and toes. Additionally, it also supplies the tibialis posterior, which causes the plantar flexion and inversion. Okay, so it is confusing enough. I know it is confusing enough. So that is why we have gathered over here. We have gathered over here to get a clue and to get some mnemonics. Okay, so the mnemonic for remembering this is SEP, superficial peroneal nerve causes eversion and plantar flexion. Superficial peroneal nerve causes eversion and plantar flexion, which are, what is the muscle that supplies is peroneus longus and brevis. Now deep peroneal nerve, the classic function is dorsiflexion at ankle and toes, which is carried out by tibialis anterior, EHL, EDL and peroneus tertius. Additional function are both eversion and inversion. Inversion caused by tibialis anterior and eversion caused by peroneus tertius. Right? So SEP, DIED, died, and tip. What is the tip? Tibial nerve, that is tibial nerve, it causes plantar flexion and inversion both. Okay, inversion is carried out by tibialis posterior. Like tibialis anterior did inversion from the deep peroneal nerve, and in the tibial nerve, tibialis posterior is doing inversion. And main function is plantar flexion, which is carried out by gastrocsoleus, tibialis posterior and FHL and FDL. Okay, so SEP, that is superficial and peroneal nerve, causes plantar flexion and eversion. Deep peroneal nerve causes dorsiflexion mainly, additionally causes inversion and eversion both. And tibial nerve causes plantar flexion and inversion. Okay, so the thing we deduce out of this is eversion is caused by superficial peroneal nerve and deep peroneal nerve both. Okay, it is caused by superficial and deep peroneal nerve, and that is the common peroneal nerve. So whenever there is a lesion, there is a common peroneal nerve lesion, whenever there is the lesion is proximal to the common peroneal nerve or common peroneal nerve is damaged, eversion is lost completely. And whenever the tibial nerve is damaged, what happens is inversion is carried out by deep peroneal nerve and tibial nerve both. So even if the tibial nerve, the inverting function of tibial nerve is lost, it is compensated by the inversion function of deep peroneal nerve, that is by tibialis anterior. Okay, so whenever, again I repeat the concept, common peroneal nerve is damaged, then eversion is lost, because both SPN and DPN, superficial and deep, are the branches of common peroneal nerve. and eversion is lost. But whenever there is tibial nerve is damaged, inversion is not lost completely because it is compensated by tibialis anterior, that is because deep peroneal nerve is intact. Okay, so these are the clues. Remember, these are the clues which will help you deduce the site of injury. Simple thing: superficial peroneal nerve, plantar flexion eversion; deep peroneal nerve, eversion, main dorsiflexion; and tibial nerve, plantar flexion and inversion. Okay, moving ahead. Sensory deficits, just a few things to remember. Superficial peroneal nerve supplies the entire dorsum of foot except the first web space and enterolateral distal leg. Right? It supplies the, as we discussed, superficial peroneal nerve supplies the lateral compartment. So it supplies the enterolateral distal leg, at the same time entire dorsum of foot except the first web space. Deep peroneal nerve supplies the first dorsal web space. Tibial nerve supplies the entire plantar aspect of foot and sole. So it divides into medial and lateral plantar nerve. Medial supplies medial 3.5, lateral supplies lateral 1.5 aspect of the sole, plantar aspect of the sole. Additionally, remember that saphenous nerve supplies the medial aspect of leg and medial border of foot, while sural nerve supplies the lateral border of foot. So this will give you a clue when you are going to trying to differentiate between superficial and deep peroneal nerve palsy. Okay, so moving ahead, we are going to discuss the most important concept. We are going to discuss the site of injury. We are going to discuss the clues. Now all the basic is clear. Now just focus on the clues. Just focus on in exam how will you diagnose the site of injury. Okay, so if it happens at the level of spine, L5 nerve root is affected. So hip abduction is affected. There is weakness in the hip abduction. Plus all other features will be there of sciatic nerve injury, flail foot, all those things. Now, if the level of injury is the sciatic nerve injury at the level of gluteal region, so what is spared? Hip abduction is spared because it is not at the spinal level, it is distal to the L5 nerve root. Okay. So what are the common etiology is posterior dislocation of hip. Now what happens if it happens at the level of gluteal region? If it happens at the level of gluteal region, the sciatic supply to hamstring occurs at the just proximal to the division at the superior pole of popliteal fossa, as we discussed. So the sciatic supply to hamstring is lost. So once hamstring supply is lost, what is lost? Knee flexion. Knee flexion is lost. Additionally, distally, everything is lost. Distally, common peroneal, tibial, both are lost. So dorsiflexion, plantar flexion, eversion, everything is lost. So there is flail, ankle and foot. Okay. So what is lost? What all things are lost and what is spared if it occurs at the level of gluteal region? Common cause, posterior dislocation of hip. Hip abduction is spared. Okay. But knee flexion is absent and there is flail, ankle and foot. The only thing working is quadriceps because it is supplied by the femoral nerve. Okay. Remember this because you have to understand if there is a sciatic nerve injury at the distal level in the thigh, then what is the difference? We will see to it. Here flexion is lost and flail, ankle and foot. Now if it happens at the level just above the popliteal fossa, if the level of sciatic nerve injury is just above the level of popliteal fossa, what happens is the injury is distal to the hamstring supply. So what happens is hamstring is spared, so knee flexion is possible. This is the characteristic thing, knee flexion is possible. So if in a patient knee flexion is present, you can say that the level of injury is distal to the hamstring supply just before the bifurcation at the superior pole of the popliteal fossa. Right? It is proximal to the division, so common peroneal and tibial both are gone. So flail, ankle and foot is a thing. Okay, so from proximal to distal if we revise quickly, hip, then loss of hip at the level of spine, the loss of hip abduction. If we come more distal before the hamstring supply, there is loss of knee flexion. If the knee flexion is present, we can say that the level of injury is more distal in the thigh just before the bifurcation. Okay. So now distal to the bifurcation, we want to understand whether it is a common peroneal nerve palsy or a tibial nerve palsy. So we are going to understand if it is a common peroneal nerve palsy, it is a case of classical foot drop. Okay. Why is just a few common questions? Why is common peroneal nerve palsy most common? Because it is injured easily. It is more lateral. It is more peripheral. At the same time, it is tethered at the fibular neck. Okay. So at the level of common peroneal nerve, so hamstring is paired. So knee flexion is possible. At the same time, tibial nerve is paired. We are going to discuss about common peroneal palsy isolated. So tibial nerve is paired. What is tibial nerve function? TIP, tip. So plantar flexion and inversion both are spared by tibialis posterior and gastrosoleus. Now the classical thing which is lost, the most important is deep peroneal nerve which is lost. So dorsiflexion at ankle and toe, that is EHL and EDL, both are lost. Dorsiflexion at ankle and both the toes is lost. So this is the classical foot drop wherein there is loss of dorsiflexion. Now about eversion and inversion. So superficial peroneal nerve is SEP. So function is eversion and plantar flexion. Deep peroneal nerve, inversion, eversion and dorsiflexion. All of them is by deep peroneal nerve. So in common peroneal nerve palsy, both superficial and deep peroneal nerve are gone. As both are gone, so there is no eversion which is possible. There is no eversion which is possible. We discussed it in previous slides as well. While inversion, though there is deep peroneal nerve palsy, so there might be weak inversion, but it is compensated by the tibial nerve because the function of tibial nerve is also TIP. So it is compensated, inversion is compensated, so there might be weak inversion, but eversion is lost. Okay. So the classical thing in common peroneal nerve palsy, hamstring spared, knee flexion possible, plantar tibial nerve spared, so plantar flexion and inversion possible. Inversion may be weak, but most important, dorsiflexion at ankle and toes is lost. So this is a classical case of foot drop which we see in common practice. What is the common thing? It is more lateral. So in the common fractures around the knee, in osteotomies, iatrogenic, compression, bandaging, slabs around prolonged splinting and immobilization around the knee, all these causes common peroneal nerve palsy commonly. Okay, so moving ahead, how do you differentiate between superficial peroneal nerve and deep peroneal nerve? Okay, so SEP, as we all know, and deep peroneal nerve, inversion, eversion and dorsiflexion. So in deep peroneal nerve palsy, there is definitely foot drop. But in isolated cases of superficial peroneal nerve palsy, there is no foot drop because the function is plantar flexion, not dorsiflexion, and it is isolated. So deep peroneal nerve is preserved, so dorsiflexion is preserved, so there is no foot drop. Additionally, the theoretical thing we studied, sensation deep peroneal nerve supplies the first web space, so sensations at the first web space are lost, while in superficial peroneal nerve the sensations at the dorsum of foot and anterolateral leg are lost. Okay, so this is how you differentiate between superficial and deep peroneal nerve. Now if the level of injury it is a tibial nerve palsy. What is tibial nerve? Tip, TIP. So inversion and plantar flexion both are damaged, both are affected. So inversion is weak, but it is compensated as we saw by deep peroneal nerve, tibialis anterior. So inversion is weak. At the same time, plantar flexion is weak at the ankle and toes both because of the tibial nerve palsy, which we discussed in the previous slides. Okay. Okay, so moving forward quickly we are going to understand the key. We are going to understand the key without further ado. If the level of injury is spine, there is weakness in knee abduction. If the level it is at the gluteal region, there is loss of knee flexion because of the hamstring damage. If it is at the level of thigh, knee flexion is spared, but there is flail ankle and foot. If it is at the level of knee, if it is common peroneal injury, dorsiflexion and eversion is lost, plantar flexion and inversion is spared. If it is superficial peroneal nerve, no foot drop. Deep peroneal nerve, foot drop is present. Sensation supply we discussed. And if it is tibial nerve palsy, plantar flexion is lost, while dorsiflexion and eversion is preserved because of the deep peroneal nerve, and weak inversion is present. Okay, so this was all. This was the most important slide to decide the site of injury. Now just a small theoretical slide. So what are the, for the foot drop, after which we are going to discuss some of the cases, some of the real time practice of how you deduce the diagnosis, you reach the diagnosis bang on to the site of injury. Just a few, one theoretical slide. What are the investigation you do depending upon the etiology? X-ray, CT scan, MRI, based on the level of injury. If it is spine, you go for, you don't want to check for a PIVD. If there is hip fracture, you want to go for CT scan based on the etiology. Additionally, you go for EMG and CV to look for the nerve conduction and electromyography. Now, management is based on this theoretical. You will get into detail from the theoretical books. So, management for neuropraxia and axonotmesis is initially observation for 9 months. In what do you do in observation? You give AFO to prevent equinus contracture. You do physiotherapy, you give vitamin supplementation, you give electrical stimulation. In neurotomesis, you go for direct primary epidural repair, that is neuroraphy, or if it is a more than 1 inch gap, you might go for nerve grafting as well. Now, some of the procedures, surgical procedures after the observation, if it doesn't work out, you might go for a tendon transfer, you might go for surgical procedures, which the tendon transfer from tibialis posterior, which is attached to the third metatarsal base. Some of the named procedure, famous procedure, Ober's, Bears, and Srinivas. Additionally, one famous procedure, Bridle's procedure, in which it is made by posterior tibial, tibialis anterior, and peroneus longus. Additionally, based on the etiopathogenesis, if it is PIVD, you go for discectomy. You might go for decompression of the sciatic nerve if it is a post-op or a post-dislocation of hip. And additionally, you might also go for arthrodesis at the ankle if it is old age and you need stability at the cost of range of motion. Okay, so this was some of the basic important things which might be asked in practical. Now, what we are going to discuss, fasten your seat belts, because we are going to discuss some of the interesting cases. We are going to discuss some of the interesting cases. So, first case is road traffic accident, 30 years male. There is swelling at the posterior aspect of hip. The first clue, this is bang on clue. What is it? It is a posterior dislocation of hip. Now, additional clues, the patient is not able to flex knee. What does it indicate? That is, there is loss of hamstring. Hamstring is lost. Hamstring is lost. So, it is a more proximal lesion. It is more proximal lesion. And additionally, the main clue is swelling at the posterior aspect of the hip and weakness in the ankle movement. So, the level of injury is at the gluteal region, which is proximal to the hamstring supply. Easy, finish. Now, second, okay, so there is a 35-year-old male who is a laborer, in the rural area. Laborer is a characteristic word. What does it indicate? It indicates there might be, in this setting, there might be a Hansen's disease as well. Okay. Now, there is the second clue is multiple hypopigmented patches. Finish. In the history itself, in the examination itself, you know that we are going towards a picture of Hansen's. History of medications for skin condition, loss of sensations in hand and toes. What is it? Glove and stocking. Okay. With weakness in ankle movement. What is your differential? First differential. Your first differential is Hansen's disease. Okay. Now moving forward, the next is 46 years old female, history of lifting heavy object, heavy object, complaints of low back pain with foot drop, with radicular pain. What is your first differential? If there is history of lifting heavy weight, your first differential, with low back pain with foot drop, your first differential is PIVD. Okay. Now, what is the next clue? Hip abduction is weak. Finish. Hip abduction is weak. So, what it is? It is L5. It is L5 nerve root compression. So, it is a L4, L5 PIVD. It is a L4, L5 PIVD. Finish. Now, the next case is a case of road traffic accident. Proximal tibia undisplaced fracture was there. Above knee slab immobilization around the knee for prolonged period. And so what is the differential? It is some immobilization around the knee. The level of injury suspected to be at the knee. Now we are going to understand whether it is proximal to common peroneal nerve and tibial nerve, whether only common peroneal nerve is damaged, whether superficial is only damaged or deep is only damaged, or it is a mechanical cause. Okay. So knee flexion is first clue is knee flexion is present. So what do you rule out? You rule out that hamstring is intact. So the level of lesion is distal to the hamstring supply at the distal aspect of thigh. Now ankle plantar flexion and inversion both are intact. So what it is? I and P. So what do you suspect? What is spared? The tibial nerve tip is spared. So tibial nerve is spared. So the level of injury is distal to the bifurcation. And now ankle dorsiflexion and eversion both are lost. Ankle dorsiflexion and eversion both are lost with preservation of ankle plantar flexion and inversion. What are you probably suspecting? You are suspecting a classical case of foot drop, that is common peroneal nerve palsy. You are suspecting a classical case of common peroneal nerve palsy. Okay, so the next case, last case, there is road traffic accident with femur fracture with foot drop and knee flexion is possible, but there is flail ankle. Knee flexion is possible. This is the characteristic key. Knee flexion is possible, so hamstring are spared. So the level of lesion is distal to the supply of hamstring. Okay, with flail ankle, that is both dorsiflexion and plantar flexion both are lost. Okay, so common peroneal nerve and tibial nerve both are lost. So the level of lesion is proximal to the division from into common peroneal nerve and tibial nerve, but it is distal to the hamstring supply. So just proximal to the division just proximal to the superior pole of the popliteal fossa, we are suspecting the level of injury. Okay, so these were some of the interesting cases which helped us in deducing bang on the site of injury, which will help us to deduce the diagnosis in practical exam. I hope you got the concept of foot drop clear. It is very interesting and logical concept. I hope you found this video useful. So what are my fees for this video? I would love to get your feedback. in the comment section. Additionally, you can drop in the feedback in my Instagram account, Mihir Tejura. You can also check out some more videos on orthopedics in my channel, Orthopaedics Simplified for You. This was Dr. Mihir Tejura signing off with foot drop simplified for you. Thank you so much, guys.